So, may I invite Dr. Purnima Madam to be moderator for this session, and it is about don't want to again incidents. Basically, in our department also, Dr. Purnima is our plan B, C, and D if everything fails. So this is what we go back to, and I think hers is the first number we dial when we feel that there is an emergency in our OT. So proper moderator there, and let me invite Dr. Garima to present her case, please.
Good afternoon, everyone. Myself, Dr. Garima Singh. I am working at Moradabad as freelance anesthetist. So my topic is don't want to face it again. It's about obstetric hemorrhage, placenta accreta. I think it's one of the nightmare for every freelancer for placenta accreta. Got a call from a center where I have been working for almost 13 years. Patient in mid-30s, she was presented for 4th lower segment cesarean that presented with placenta accreta. The ops unit had arranged 5 units of whole blood and 3 FFP. When I saw the patient in OT, investigations were normal except for her HB was 7.8 and 1 unit of whole blood was started and 4 units were in hand. When I saw the urine bag, there was frank blood in the bag, 50 ml of frank blood. And catheter has been inserted 3 hours ago so that iatrogenic injury was ruled out. On further inquiry, she told that she has been passing urine normally, but since morning she had frank hematuria, and that prompted her to visit the hospital. She was 7.5 months pregnant. On ultrasound examination, there were clots in the bladder, and she was in severe pain, and hence the decision to go ahead with LSCS. So now, obviously my plan was GA as I was expecting massive blood loss in this case. Clinically, her HB doesn't seem to be more than 5, and I informed surgeon that patient is still bleeding. And my experience says if during intubation, if you find the glottis severely pale, then definitely HB is going to be less than 5. So how did I do it? I induced with fentanyl, propofol, and scoline and intubated, and section was done. Within 2 to 3 minutes, baby was out. There was huge distended bladder just beside the uterus, and the patient was bleeding profusely. The surgeons were not able to reach the cervix, so they decided to go with the partial ops hysterectomy was done, but still she was bleeding continuously. So by this time, her BP started dropping very rapidly. 2 IV cannulas were already there, and my favorite external jugular vein was cannulated. 2 bloods started simultaneously, followed by 2 units of FFP, and this was then followed by 2 units of RL and 2 more units of whole blood. In total, patient had received all the 5 units of blood and 2 FFP, and BP was still fluctuating between 60 and 80 systolic, and her pulse rate was 160 per minute. And there was no urine in the urine bag, as most likely the clot in the bladder had blocked it. So bladder had got distended significantly, and it appeared that the blood was collecting in the bladder. The BP continued to drop, and systolic BP was reaching around 60, and this was alarming, and surgeon's help was sought. So the BP continued to drop and was now around 60 systolic. So at this point, I decided to start her on Norette infusion with 2 ampules in the 50 ml of normal saline at the rate of 4 ml per hour. The general surgeon arrived in 20 minutes. He decided to open the bladder as it was getting distended. There were clots of approximately 700 to 800 ml, which was evacuated. Even after bladder repair, patient continued to bleed. By this time, 2 units of whole blood were arranged and administered. 1 ampule of calcium gluconate with the induction tranexamic acid was administered. Patient was still bleeding, but I was able to maintain systolic BP above 100 with Norette support. Now what next? I was quite calm in the OT. I firmly told the surgeon to take his time, but be quick in taking any decision, otherwise we would lose the patient. So they decided for the bilateral internal iliac artery ligation. After ligation, major bleeding was definitely controlled, but the raw area continued to ooze. By this time, 7 units of blood arrived, and it was started while abdomen was pegged, and we waited for a few minutes. By this time, patient had started making some urine. It was only 50 ml, but blood stained. More FFP and the fresh blood were demanded. After waiting for about 10 to 15 minutes, bleeding had almost stopped and abdomen was closed. The whole procedure took almost 2.5 hours. During this period, patient was maintained with oxygen, nitrous and atracurium. Initially, isoflurane was used, but when BP dropped, it was stopped briefly, and once the BP maintained with NORAD, it was started again. In between, I administered the second dose of fentanyl, as in such cases, maintaining the patient in deeper plane is very necessary to prevent patient going into pulmonary edema due to lighter plane of anesthesia. Because in such patient, when we do when the massive blood transfusion is done, and lot of fluid is given, so there are the chances of patient can go into pulmonary edema. So in such patient, to maintain the patient in deeper plane is also very necessary. As soon as surgery was over, neuromuscular blockade was reversed and patient was following verbal commands. Post-operatively, NORAD infusion was continued. In this case, I decided to extubate the patient on table because, first of all, I working as a freelancer. In that hospital, there is no ICU backup. Second thing, the patient lungs, preoperatively patient lungs were normal, and I was quite confident about that I can reverse the patient very nicely rather than shifting the patient to another hospital for the overnight ventilation. So there is a spectrum called placenta accreta spectrum. This order broad term that includes 3 subtypes. There is placenta accreta, placenta increta, and the placenta percreta. In the placenta accreta, anchoring placenta villi attached to the myometrium. In placenta increta, anchoring placenta villi penetrate into the myometrium. And placenta percreta, anchoring placental villi penetrate through the myometrium to the uterine serosa or adjacent organs. The International Federation of Gynecology and Obstetrics classification of PAS, grade 1, grade 2, grade 3. Grade 1, abnormally adherent placenta, that is placenta adherenta. Grade 2, abnormally invasive placenta increta. And grade 3, abnormally invasive placenta percreta. Subtype 3A, limited to the uterine serosa. Subtype 3B, urinary bladder invasion. And subtype 3C, invasion of other pelvic tissues and organs. Thank you.
Dr. Karima, diagnosis of placenta accreta was made pre-op only on ultrasound?
Yes, sir.
The gynecologist and you were aware of the invasion of the placenta into the urinary bladder?
So I was not informed that it is invading the urinary bladder also. But when I asked the gynecologist why there is a frank urine in the urine bag, then she told that there is a slight invasion of the bladder. They were not very sure. Maybe like they were hiding from me. That can also possible.
As a freelancer,
it happens like in private practice because directly we get the call from them कि मैम एक केस है बस आप आ जाइए.
Yeah, perfectly understandable. But if in our scenario, if we get a call for a cesarean with placenta accreta, where the invasion is not really known, so pre-op we go ahead with good invasive lines, and we tell the gynecologist, if she is not very skilled one or he or she is not skilled one, to have a help in the OT. Because these patients, I mean, you were very fortunate to salvage the patient, but the extent of bleeding is so much that these patients collapse on the OT table. And because I am given to understand that it was a type 3B.
Yeah.
Right? These kind of patients, they lose a lot of blood.
Yeah.
And
actually after opening
and in our scenario, we electively ventilate if there is major blood loss. And we then, as per the recommendation, we replace a pack RBC with 1 FFP and 1 platelet. For any major blood loss, we go ahead with that kind of a policy.
Yes, sir.
Why you maintain systolic blood pressure of 100 when patient was feeling like 1? And secondly, why you attract in answer patient you avoid attract?
So usually,
Not really.
So we use like to paralyze the patient. That is also very important when already there is a lot of bleeding. So like I would like to use atracurium only in such patient because there is already a lot of bleeding and the patient is and the surgeon is not able to what else we can use instead of atracurium? Then what else we can use instead of atracurium?
See, I have seen few patients of atracurium-induced histamine release. So I will not use atracurium if patient is unstable hemodynamically. Secondly, if patient is having active bleed, and it is better to keep blood pressure around, systolic blood pressure around 70, 80 rather than going for a higher up around 100.
But sir, if like to maintain the renal perfusion also, and like
You can do that. Young patient, you tolerate.
Yeah, but I wanted to be on safer side.
Fair
so because like as a freelancer, sometimes the things are totally different what we practice in a corporate hospital. So I wanted to have BP above 100 so that renal perfusion, and so I wanted actually some urine. The patient should make some urine, otherwise like it will be difficult to extubate the patient on table.
I think anesthesia is a cafeteria choice.
Yes,
what
yes.
one is
I believe
comfortable using
systolic
it.
BP
Basically, in the breakfast, it can be a dosa also, and it can be a puri also, something like this. So I think whatever one is comfortable with and keeping his patient safe, I think till that time, I think everything goes. We have seen what we have done and what we are doing. So whatever one is comfortable in the setup, I think that is the best thing to do.
Yeah, I disagree with Vimon here. I feel 100 systolic BP is fair enough.
Yeah.
And it will not create any bleeding. I don't think it will. It will be a cause for bleeding. And maintaining, as told by Garima, maintaining 100 systolic will help to prevent any kidney damage also.
And so,
That is my
pardon, like
view.
sir, as a freelancer, like sir, we have been dealt with many cases of placenta accreta, and most of the cases, like when we enter the OT, then only we came to know, oh, there is a placenta accreta, and they have hardly arranged for. Now they have started arranging FFP. Pehle to they only used to arrange whole blood. Never they used to arrange FFP. Then after like counseling them, you should arrange for FFP. Still, I demand for the platelet, but still they're not like the surgeon. They're not at all ready to get the platelet. So sometimes it becomes very difficult to even educate them in a small town, basically to the gynecologist. And
Dr.
Next
Garima,
question.
Dr. Garima, last thing. One thing that you got away with it, you did a good job, and you were lucky also. In freelance practice, I'm a freelancer. I've been in a situation where you have been. I was lucky to get away with it. Not once, but twice. Third time it was a known accreta, and we arranged around 5 units blood and 3 or 4 FFPs, and again we were barely able to save the patient. Lucky 3 times. I decided I am not going to have a 4th try. Any such patient accreta comes in freelance practice, we refer them to an institution which have the blood bank, FFP, all other products freely available, so that no one has to run around. Again, well done, good job.
thank you, sir.
Any other questions? If there are, yes, Chitra.
Garima, I'm Dr. Chitra from Delhi. I just wanted to really applaud on the way you managed and kept your cool. It was amazing. One thing is keeping your cool, so half the work is done. But how long do you take to get the FFP and blood? Like you immediately, I mean, how is the emergency in? So the surgeons were aware of it. And
Placenta accreta, but they were not very much aware of that. It's an invasion of bladder also.
okay.
I'm surprised
And other
with
than
so
not,
much of
As soon as
blood in
as soon
the
as
urine bag.
They opened the abdomen. There was the bladder was hugely distended, and there was no urine was.
and
coming
what
out.
did they do to the bladder? Because you said
They opened the bladder and they evacuated the blood clot. Then again they repaired the bladder, but still the patient was.
but the placenta wasn't getting into the bladder. I mean, that means it
Must
had
have
not.
been.
Huh?
Must have been.
Okay.
It must have been invading into the bladder. Otherwise, how would
So they must
she
have
have
taken
so
out
much
a
of
bit of the bladder
hematuria?
also. Okay.
And one more thing, sir, just like you were saying, sir, ki in the private, as a freelancer, like you should have the invasive line and the, like you were telling, but I think in the like I have done more than, I think 10-12% accreta cases, and luckily I was like, luckily and all the patient I have extubated per op on table only, and the placenta accreta, my one of the favorite is the EJV, external jugular vein. If you can get the external jugular vein and you can cannulate the 16, so IJV ki bhi, I don't think there's any need of IJV. So external jugular vein is my USP कह लीजिए आप, जो usually the people have afraid of going into that, but if you can get the EJV, then equally you can like infuse the...
Yeah.
Just one more question I wanted to ask now. Like this was a documented case of percreta. What is the role of, I know it's not available in the freelancing practice, what is the role of preoperative bilateral internal artery embolization?
Ma'am, practically, I haven't heard ki practically anyone is doing in the, as a nursing, in a nursing home. So like in last time also like the same case was there, and in that case also the surgeon did the bilateral internal ligation. And the embolization I have no idea, because I have never seen like anyone doing in a private nursing home.
I think in this case the placenta was in the bladder, it means a different case, but if there is accreta only limited to the uterus, then I think the obstetrician should go for upper cesarean section and fundus approach, take out the baby, don't handle with placenta at all, clamp and do the uterus and come out.
But nowadays most of the gynecologists, they don't take out the placenta, they just take out the baby.
Yes.
And they already they plan the obstetric hysterectomy.
Yes, obstetric hysterectomy, and that will save the patient and will not cause any bleeding intraoperatively.
In most of the cases of placenta accreta, we have taken the consent for obstetric hysterectomy in advance only.
In advance, yes. This is very important. We should take the consent for hysterectomy in advance, go for elective hysterectomy as soon as the baby is out, just go for hysterectomy, put the clamps and come out. Don't handle with the placenta at all.
In this case, when I came in the OT, so I have a habit of taking all the parent, looking at the patient, taking all the parent. I asked the staff ki ये तो फ्रैंक ब्लड है 50 ml का, तो बोला हाँ, तो मैंने कहा समथिंग इज देयर लाइक, तो मैंने कहा ये केस यहाँ पे नहीं करना चाहिए, पेशेंट को शिफ्ट करो. तो तभी दाड़ के gynecologist came, अरे कुछ नहीं होता है, नहीं ये करके like, and they like, if I refuse then somebody else will come.
We have lost some another yes, the gynecologist has lost because they started to pulling, देख लेंगे, bleeding होगी तो कर लेंगे types नहीं. Electively we have to go for.
Sorry to interrupt. In my institution or whenever you are handling accreta in the institution-based practice, we can have an intervention radiologist targeting the iliac artery. We can do that, put a balloon there, and they can be present inside the theater where they alternately inflate and deflate both sides. This reduces the bleeding, as well as we have done a couple of cases like that, and we have been quite lucky with, I think, majority one unit had to be transfused at the most. So this is a institutional based practice which
I just see these cases, practical cases were kept just to generate this discussion, and I am very happy that the food has not affected the cognitive functions here. But I just want to add one thing. It takes a real amount of courage to become a Columbus and set sail. Autopsy is the easiest sign, and everybody in Einstein. It happens in the department also. Whenever some colleague faces trouble, all others jump and give suggestions and all that. Really good to have that feeling in the conference hall also.
Yeah, that's human tendency.
And that's a human tendency, and we really appreciate that the patient, anesthetist and the surgeon both are safe, because this is very important in the present times to ensure the safety of everyone. Thank you.
Excellent
presentation. Let's proceed.
A very good afternoon, and at the outset I thank TAS for giving me this opportunity to be here with all my Facebook friends, and it's really good to interact with you personally. Myself, Dr. Harjinder Kruri, I bring greetings from Punjab. I am working in Deep Nursing Home, which is a setup between a nursing home and a corporate setup. So greetings from my state of Ludhiana, state of Punjab, Ludhiana. So I hope the same watchfulness and alertness is maintained during this session. So an error does not really become a mistake until you refuse to correct it. It is actually a bridge between inexperience and wisdom. Medication errors can be devastating, so one has to detect, devise, and diffuse it. My presentation, a 34-year-old male, ASA grade 1, posted for examination under anesthesia and fistulectomy. Fasting, investigations, consent, all in place. He came to the OT, 20 gauge cannula was there, and injection Metrogel 500 mg was on flow. Monitoring was all started. And the plan was to give saddle block with 2.5 ml of 0.75% ropivacaine. And note, this was a new drug in our armamentarium. This is about 5 months back. So I always prefer to allay the anxiety by giving injection midazolam 1 to 2 milligrams slowly if not contraindicated. I asked a reliable technician, anesthesia technician, to give injection midazolam 2 milligram IV slow while the patient was sitting. The closed loop communication was followed here. Spinal was done in single shot, but I noticed the head drop, thought it was a midazolam magic. Suddenly I noticed abnormal feet movement and made him supine, saw a rash over the trunk and sweating all over the forehead. Oxygenation was started immediately. Patient was breathing but bedazzled. So, self-doubt first was, have I injected a wrong drug intrathecally? But I loaded the drug myself, so was quite confident, rechecked and it was fine. Then came the bolt from the blue. I was told, ma'am, it is atrocurium, 2 ml. That is 2 milligrams of atrocurium was given and not midazolam. So you can see this. This is a perfect recipe for disaster that I faced. 2 different pharmaceutical companies, same volume, 10 ml of the drug in each. One is atrocurium and the other is midazolam. Immediately I asked my technician to give injection propofol 80 milligrams and tramadol 50 milligrams. Started with IPPV. The surgeon was comfortable. He never asked why you are started with IPPV or oxygen. He was very comfortable. Procedure lasted for about 25 minutes. Patient was comfortable. Vitals all maintained. Reversal was given. So when the patient woke up, he said, a drug swept me off my feet. Just assured him all is well. Never shouted, lost my calm, and things are still okay between the technician and myself, though many apologies followed. No one in the OT except her and me knew what exactly had happened. Reported the incidents without creating a ruckus. Probably Almighty took notice of some good karma of my previous birth. So what are the lessons learned? Trust your instincts. Maintain calm but act expeditiously. Check, recheck before loading the drugs. Circumstances could be any, but it's your attitude, approach and response that matters. Accept your mistake and pledge to play safe. So don't let this happen to you. So the taxonomy of medical error is vast, colorful and at times very confusing. There are slips, lapses, harmless hits, near misses, errors of omission, errors of commission, operator errors, system errors, accidents, complications and bad outcomes. So just a brief interview, the learning objectives that we have to understand what are the risk factors and why it is specifically to anesthesia that these errors are more, and guidelines. So medication errors can be any, a wide plethora, calculation mistakes, wrong drugs, incorrect labels, syringe swaps, ampule swaps, and the list is never ending. So any event, let the medication not become your adverse drug events. So any event may lead to or harm in inappropriate medication is a drug error, and all of these, most of these are preventable. So these can occur at various stages: prescribing, ordering, communication, product labeling, packaging, nomenclature, compounding, dispensing, distributing, administrating. So let the adverse effects, all these medication errors, 1/3 of them are likely to harm the patient, and more than 2/3 are still having a potential to harm. So the aim is to prevent before it happens. Estimated about 44,000 to 98 hospitalized patients in US die because of medical errors, and the figures are much more in our country. Medication errors is 7th most common cause of mortality in hospitalized patients. Adverse events occur in about 16.6% of the hospitalized admissions, and mind you, 51% of these are highly preventable. Risk factors are many. Most common are inexperience, non-familiarity with the drugs and the equipment, and communication. Communication is the key. And other factors, they also have a role to play. Now, a National Coordinating Council on Medical Errors and Reporting and Prevention, they have categorized the errors into 9 categories, where no error is there, but there is no harm. There is an error, the harm has been done, but then there are strategies to prevent. And the most devastating, where the error is there and it has culminated in death. So most of the errors are near misses, and so the adverse outcomes may either be good due to the fortune being good, on your side, timely it's being noticed and interventions done. The best way to treat a drug error is, of course, to prevent it. So there are many kinds of unsafe events. Some of them are intended like mistakes and violations, like we fail to check our machines, and others are unintended. Many slips, lapses and mistakes. And when the conditions become favorable for them to, then it results in errors. So the literature has also shown us that the error per anesthetic ranges from 1:133 to 1:450. And most common cause is the incorrect dose. There may be substitutions, there may be omissions, repetitions, insertions, incorrect route, others. That includes the choosing of the wrong drug at the outset. So how is a human being involved in all this? There is a complex interaction between the humans, the environment and the technology. So there is a role of checklists, drills and simulations. Team dynamics are very important. Teamwork, knowledge sharing, leadership, interpersonal communication is imperative. Besides the technical skills and knowledge, it is the anesthesiologist's non-technical skills, task management, leadership qualities, situational awareness and decision making is very important. So latent conditions are always there. That includes your organization processes, your management there. The errors are bound to happen because of the individuals, the tasks at work, your communication skills with your team, and errors are always there to happen. Whenever the defenses are breached, the accident is likely to happen. This was very nicely given by the Swiss cheese model by James Reason. He said that in all the institutions, in all the big hospitals, the defense mechanisms are in place. They are at multiple levels, and this is represented by the Swiss cheese layers. And also there are certain holes, there are certain lapses there. When all these holes align, it's a perfect recipe for a disaster to occur. So that once these defense mechanisms are breached, nobody can help stop the error being done. So as we have seen, there are many levels at which the errors can occur, right from prescription to administration to documentation to dispensation. So I'm not going to do detail, all of us know about this. Why medication errors are more in anesthesia? Why? Because the delivery of most potent drugs in rapid succession, one after the other, it happens in our field. Then the provider has the own responsibility of preparing, dosing, delivering the medications to these patients. There is no check by a second provider. Also, the survey has shown that we are dealing with a complex group of patients who are on many drugs. We deal with from the pediatric patients to the geriatric patients. Also, polypharmacy is there. These patients are into a number of other drugs. Then we are dealing with the pregnant patients. So all these patients, the situations are such sometimes that emergency hours are there, or the case demands too much of stress on us. So a survey has shown that 687 anesthesiologists revealed 85% of them had a drug error or near mishap in the clinical practice. Longer the procedure, more are their administrations, more is the chances of getting a drug error there. So best practical recommendations by the Institute of Safe Medical Practice that epidural tubings without ports should be there, and there should be proper labeling. There should be proper color coding. Smart infusion pumps need to be used. Barcode technology, where as soon as the syringes are there scanned, the syringes get labeled with the drugs, with the right kind of dosage, with the kind of drug, with the concentration, and the color coding. Automatic dispensing cabinets, standardized concentrations, dilutes, and container sizes. We have to improve our labeling. They should be more legible and bigger in size. And most importantly, do not store unusual drugs in the usual locations. Always try to keep the local anesthetics preservative free in your drawers. Also, we have to improve on our standardization, technology, use pre-mixed syringes, and we have to adapt a different culture. So all this is self-explanatory. It should be, there should be, the errors can occur before prescribing, so one has to be sure it is the right patient, right prescription, while prescribing appropriate medication, appropriate to the age and weight of the patient, right choice, right dose, right route, right duration, right labeling, all goes a long way in preventing the drug errors. So this is also that all the ampoule syringes, they have to be labeled, they have to checked, rechecked, legibility of the contents should be there, syringes should always be labeled, and it is preferred that the person who is loading the drug should be giving the drug. Also, we have to avoid the packaging and presentation of these drugs. Like after this episode, we went to our inventory and we told them that this type of drugs should not be there in the inventory. So, a rechecking and reallocation of the drugs was done after this. So, errors would be happening, they have to be reported, and they have to be reviewed to improve the quality. So, all these things have to be taken care of. So medication errors, one of the most common error is also residual anesthetic drugs in the IV lines. This can also have devastating consequences. We have to change the approach. Adverse events are here to stay. They are inevitable. But we all see this as personal and professional failures. So naming, blaming, shamming that this person is incompetent. We have to change this viewpoint. Perfection is just a mindset. So accept that errors are here to be there, they are inevitable, accept this as human fallibility, and design the system. Engineer your system so that it is more friendly and safety proof. There are many medical legal aspects also, so we have to be vigilant, just not vigilant, extremely vigilant, and have a careful and watchful eye. So, despite the best efforts, increased use of technology, high standards of both invasive and non-invasive monitoring, medical errors continue to occur in the best of the centers. Simple vigilance, standardized protocols, think before you act is there to stay, and we have to avoid the medication errors. So, to conclude, it isn't just making the mistakes that is critical. It's correcting them and getting on with the principal task. Thank you.
Those 15% were telling a lie.
So.
The patient told that a drug swept me off the feet. So I told it's okay. There was a drug error. I told that patient. In the other way, that I told that maybe there's some interaction between your Metrogyl that was going and the drug we gave. Did not tell the patient exactly what happened because we knew it. It was just between me and my technician. We just told that some kind of, yes, some drug was given which actually.
I think, Pooja, this practice of informing the patient after the problems happen has come in Australia, I feel. How many times you informed in Chennai is an open secret, right? Thanks. So the thing is that
most of us hide our errors, so I appreciate that, and I appreciate the way you built the entire presentation around that thing and conveyed all the important information. So I wanted one practical answer from you, which I was hoping to see. What practice change did you put in your place in your OT to make sure this doesn't happen again, not only in your with you, but with XYZ? That I would have liked to see that also in your presentation.
Yes, ma'am. I told that after this we changed our inventory. We told that such drugs, because these were drugs from two different companies. So we told that this thing should not happen, and after this, whenever we were doing a case under regional anesthesia, we made sure that no relaxant is there on our trolley. It is always in the refrigerator, which is within the OT premises. So these two changes which we definitely made in our armamentarium.
I would like to say very well managed, but why didn't you think of something like iGel or this instead of just doing IPP with mask? Wouldn't atracurium you have given, you knew it will go for at least 15-20 minutes.
So just 20 milligram was given, the patient was conscious, he was breathing, and sir, ek baar to hota hai ki let's hide what we have given. Okay. So I told you my surgeon was very comfortable, he never questioned me because he knew me for a long time. I've been with him for last 15 years now.
You did give propofol.
Yes, I gave propofol, I gave tramadol also. So I wanted the patient to sleep for those 20 minutes. I knew the drug effect is going to be over in those 20 minutes because the dose was inadequate, which was just 20 milligrams of atracurium.
The thing is that it really requires a very skilled anesthetist to harm the patient, right? So because the word skill itself has a kill in it, right? So intrinsically we all know when we go back at the end of the day after such incidents, how many times we have invoked the spirits or taken help of spirits to drown these incidents, right?
Hello.
So let's proceed with the next case. May I invite...
can I have one just thing? It's a wonderful presentation. Possibly, I don't think anyone will say this is the most important topic in the whole conference. So there is no doubt in that. I will tell you, in last 15-17 years practice, I had 2-3 medication error for first 2 years. Followed by next 12 years, I never had even one, not even near miss. The reason why I'm telling, when my boss was there, we are very policy-driven hospital. When my boss suggested one, we will go something, we call it independent double verification. So what happens, the technician when picks up an ampule, he tells verbally, like from audible, injection glycopyrrole 0.5 mg per 2 ml. He hands over to the anesthetist. He will again read injection glycopyrrole 0.25 ml. Initially we were like, humans are resistant to change. We said this mad fellow has gone mad, what is nonsense, then he will say 3 people. But imagine the impact in a hospital of 250 obstetric hospital, where we do category 1 section like every in and there. We don't have a medication there for 9 years. We were very resistant. We were shouting at him. So this one, if we practice, and it takes 5 minutes to train the staffs. It's like a drama. Do this one, give it, while I'm so double independent and verbal verification. This, if you can try, I might suggest something which I've seen the result despite objecting to it.
Thanks Siva for your inputs. May I invite now Dr. Aparna Sinha. Ma'am doesn't require any introduction because if I start, it will be a very fat one for the topic which she is taking, right? So ma'am is taking how to prepare an obese patient for a surgery, and definitely coming from the expert, ma'am, looking forward to a good talk. Thank you.
Thank you so much, Anil, for your very, very kind introduction. So good afternoon, everybody. Good afternoon, Chairperson, Dr. Purnima. And at the outset, I really want to congratulate Dr. Anil and Dr. Hetal and all the office bearers to organize TASCON, and it's really a pleasure being here. So coming to the topic, at the outset, I bring greetings from my hospital, Max Institute of Laparoscopy, Endoscopy and Bariatric Surgery at Max Saket. So at the outset, I have no disclosures to make and no conflicts of interest whatsoever. My lecture is based on current evidence and my personal experience. So I'm going to talk about something that is really very vital, preoperative assessment and preparation of patients with morbid obesity. Now, why is it important? Now, this topic is a topic of increasing importance, not just for people who are talking about bariatric surgery, because we all are aware in our practice, no matter which part of the country, which, whether we are from a small town or a big city, we all are, encountering obese patients with increasing frequency. We all would accept it. So what is it that is different about these patients, and how we can make the anesthesia experience for these patients a little safer? So what are we going to learn today? What are the anesthetic challenges in patients with morbid obesity? Which obese patients are at risk? How do we select our patients, and how do we optimize them and make the perioperative experience safer for them? So the purpose of preoperative assessment, of course, is to identify the anesthetic challenges, identify the patients with high-risk conditions, optimize the comorbid conditions, and identify those patients who may require periodic assessment. Of course, I'm talking about elective surgery. If it's an emergency surgery, then we have to find ways to go straight away towards the surgical experience. But more or less, the topic deals with elective surgeries. So this is like a very landmark study, which I think I mention in practically every talk that I take. Now, this was a landmark study that was conducted by American College of Surgeons and published in their journal, where they examined more than 11,000 patients, and they developed a multi-center national surgical quality improvement data set, and they try to risk stratify and identify those patients who are at greater risk. So I'm taking up only the risks that are of anesthesiologists' concern. So they defined the adverse outcomes. So they said if a patient requires more than 48 hours of ventilation, if a patient needs to be reintubated, if a patient develops a post-operative renal insufficiency, rhabdomyolysis, a cardiac insult, or requires an unplanned blood transfusion, patient returns to the OT for any reason, or develops a venous thromboembolism, to name a few. These were categorized as major adverse outcomes. So when I'm selecting my patient, I have to first keep these facts at the forefront of my mind, that when I'm going to give anesthesia to these patients, I should not encounter any of these problems. So they further found that the patients who have dependent physical status, recent MI, which means MI in less than past 6 months, angina less than 1 month, a bleeding disorder, hypertensive patients. Now, hypertension is something that we should not take lightly, that it is so common. Most of the times, hypertension in these patients is underdiagnosed, or patients with extreme BMI. Now, these are the patients who are likely to develop these outcomes. So, our focus while selecting the patients should be towards these outcomes. So these findings support the very fact that should be a careful patient selection and aggressive preoperative optimization. So for preoperative optimization, how do I identify my patient? Now, what are the anesthesiologist's main concerns? Now, there are a lot of history that the patient would give and things that would be very obvious. But we are talking about those issues, they are hidden issues. And it is sole responsibility of the anesthesiologist to unravel those issues. So this can be done mostly by general physical examination or by assessment of oxygen reserves. So simple thing like general physical examination. Did I auscultate my patient properly? Now, if I am examining especially a female patient, if the environment is noisy, I am more likely than not going to miss many findings. So if I am putting a stethoscope on my patient, especially in female patients, I should be standing behind the patient and ensure that the environment is a little quiet, because most of the times the sounds will be muffled sounds. Now then things like, if I am seeing a patient who is breathless, looking at the neck, now there might be so much fat around the neck that I might miss a raised JVP. So just looking at the neck, I may not be be able to detect if my patient is in failure. Now, a simple breathless obese patient might be in just a simple physical deconditioning, in the sense that, patient may be so used to being sedentary, maybe because of massive pedal edema, maybe because of severe osteoarthritis, that even slightest of movement may make the patient breathless. Then it is for us to identify whether this patient is in any sort of cardiorespiratory failure. So the general physical examination has to be targeted towards that. Now, simple things like taking the blood pressure. The patient may tell us that, I've never had hypertension. But what was the method of taking the blood pressure? Was the right cuff used? Now, most of these patients, I'm talking about super obesity or morbid obesity, in Indian population would be having conical arms. Now, there are countries where conical BP cuffs are available. But in country like ours, where I don't think they are yet available, then the choice of the correct size of BP cuff also matters. So even, it has been proven that even a smaller cuff, if it is well fitting on a forearm, will give us accurate blood pressure. So close attention should be paid to how at all I am recording the blood pressure. Now, about the preoperative cardiac assessment. Now, the American College of Surgeons of Heart Association, they insist that, these sort of patients, we have to find out the cardiorespiratory reserve, and that can be done by subjecting the patient to some sort of a stress test. Now, is it possible to conduct echo in all the obese patients? I don't think so. A lot of times the echocardiographists will tell us that, they had poor acoustic window. They could not, find out the chamber size properly. They could not figure out if there is any regional wall motion abnormality. So, and if the patient, with a severe osteoarthritis, might not be possible to subject them to a treadmill. Moreover, there are challenges with that, because the treadmills that are available in most of the places have a weight bearing capacity of 150 kg. So that, most patients cannot be subject to a exercise testing as well. So some patients might require transthoracic echocardiography. So all centers would not provide, would have provision for these things. So what is the way forward? Now, if we read this article, I would really recommend that all of us should go through these articles, which are they really insist on the importance of basic test. Assess the effort tolerance. Go for basic tests. Look at the ECG. Are there signs of right ventricular hypertrophy? Are there signs of right-sided workload? Is there any sign of left bundle branch block, which would be suggestive of coronary artery disease? How is the X-ray like? Now, X-ray itself will show us cardiac enlargement. All will show, restricted pulmonary fields. So there is no point in going for pulmonary function test in all the patients unless we are expecting some sort of a coexisting obstructive pathology also. So many times the basic investigations that we do can be very, very informative. If we are doing an echo, then we must insist on finding out what the right ventricular systolic pressure is like, because that is what will be indicative of any pulmonary hypoxemia that might be happening. So if we look at our tests very closely, we will get a great idea about what is the present condition of the patient. Then I will also like to bring to your notice about this study that was published in New England Journal of Medicine in 2016. Now, this is another very important study where they followed 2.3 million adolescents into cardiovascular death in the adulthood. And what did they find? They found that most of the cardiovascular death could be could be traced to raised BMI in their younger days. So when we are taking history, it is also important to find out for how many years is my patient obese. So longer the stay of obesity, greater is the load on the cardiorespiratory reserves. So find out what are known as the pound years. So any pound year of more than 10 becomes a high risk factor. So please try to, take out this article and go through it. Then evaluation of the pulmonary reserves. Now, we know that just a large patient doesn't need a large lung. So constantly the lungs are under pressure of all the fat that is surrounding the chest wall and even in the abdominal cavity. So everything is pressing the lungs and constricting the lung to a very small size. So invariably, most of the patients would have a restrictive lung disease. So severe restriction of breathing capacity, restricted chest physiology, hypoxemia and hypercapnia, leading ultimately in long-standing cases to pulmonary hypertension. So if the pound years are more, then it should point us out to unravel whether the patient has any element of pulmonary hypertension. So investigations like chest X-ray, simple things like breath holding time, baseline oxygen SpO2, these things should be assessed and documented. So we might be coming, from a center where all the advanced tests are not available, but basic tests are also very informative. Then pre-op assessment for obstructive sleep apnea. Now, this is also something that we should look for. Now, why do we need to look for it? There's so many studies, enough and more. Now, this is one of the studies where they studied more than 1 lakh patients who were suffering from sleep disordered breathing. And they found that is in these patients that post-operative cardiac events, respiratory failure, requirement for unplanned non-invasive ventilation and re-intubation was very high. So it becomes very important for us to find out which of my patient is sleep apneic. So we cannot rely on polysomnography for every patient. So simple things like a clinical scoring system, whatever we are comfortable with. So Stomp Bank scoring has become very popular and very, very widely used, which is a very happy thing to know. So wherever possible, try to record the Stomp Bank score in the PAC form. Try to record the neck circumference. Try to record the BMI. If I am working in a very busy center, even the, the staff which is sitting at the admission desk, which is recording the basic demographics, can be given a measuring tape to measure the neck circumference. The Stomp Bank score itself has gone to the next level, and they say that in the stop part, if the patient is male gender, BMI more than 35 and having a large neck circumference, irrespective of what the Stomp Bank score is, we should have a high index of suspicion of the patient having a obstructive sleep apnea. So definitely we need to be more cautious in these patients. So what's the worry in these patients? Now they would be having extremely diminished oxygen reserves. They're very, very prone to airway obstruction and hypoxemia in the perioperative period. They're very sensitive to the sedatives. They have long-standing cases, would have some element of pulmonary hypertension, and these are the patients who might be failure to extubate and even failure to ambulate. So what are the other major factors that we need to look into, other challenges to the airway? Sorry, I have to really fly through all my slides because I really want to cover as much aspects of challenges in the preoperative period as we can. So what are the challenges to the airway? Now these would be the patients, especially the ones with large neck circumference, who would be difficult to mask ventilate. They might be having difficult laryngoscopy because there is pad of fat behind the neck. So when I'm doing my general physical examination, that is another thing that I must note, that this is the patient who would be difficult to position. This is the patient who might require multiple attempts at laryngoscopy, difficulty in intubation, difficulty in extubation, and multiple attempts and even difficult positioning. So these things we have to get into the habit of recording in our pre-op assessment. Now short, thick neck, unidentifiable landmarks, difficult external manipulation of the cricoid, difficult cricoid pressure, difficult surgical access. So we cannot say that, in case of problem, front of neck access is the only answer. No, I have to find out these patients, which can be a real problem to the anesthesiologist. It is not that every patient would have such problem, but a patient who comes with this sort of a neck, we definitely need to red flag these patients. When I am conducting anesthesia for such patient, all my equipment should be ready. There should be an expert help available just in case I land up in a cannot ventilate, cannot oxygenate scenario. Find out the patients who we might have to, plan for an awake, and patient with limited mouth opening, patient with poor jaw protrusion, that is upper lip bite test. So we must start getting into habit of revisiting these examination techniques again and again. So having the expert help available is the key to safety. So while optimizing the airway, we have to focus on improving the oxygenation, improving the lung volume, and relieving the obstruction all at the same go. How do I do that? So hypoxemia, the anesthesiologist is going to encounter at every step. So right in the preoperative period, the anesthesiologist, which is riding on this horse, has to be prepared for every step that is going to be more difficult than the previous. So the preparation starts right in the preoperative period. So positioning is of prime importance. Why is it of prime importance? Because right by making the patient propped up by 25 to 30 degree, we open up the airway. The stomach falls away from the lungs. The pressure on the glottis goes down. The airway opens up. So this patient, even if I have to give a small dose of sedative, might give me more room for ventilation. So we cannot underestimate the importance of positioning. So what are the other steps that we take to build up the safe apnea time? Putting the patient in head-up position, educating the patient the importance of deep breathing exercises. Pre-induction CPAP might be needed in some patients because not only it will help us in improving the pharyngeal airway patency, but also in recruiting more and more alveoli. And at the back of my mind, I must know that when I am pre-oxygenating the patient, I have to elevate the end tidal oxygen to more than 90%. Only then I can have a wide safe apnea time. Then patients with large neck, with poor Mallampati score, and if we are getting used to point of care ultrasound, we must start identifying patients who have a pretracheal fat, which by repeatedly training ourselves with the ultrasound that is available in the operation theatre, anything more than 2.5 centimeter in front of the glottis will make the ventilation and laryngoscopy difficult. So these patients should call for more help. Identified patients who would need reassessment, patients with poor breath holding time, patients with any challenge with airway. Lazy lethargic patient is suggestive of a low baseline oxygen reserves. Pedal edema. Now if a patient has pedal edema, we need to really investigate that patient more. Why? What are the causes? It may be a dependent pedal edema, they may be venous stasis, they may be varicose veins, there might be a clot sitting there. So we need to investigate this patient. Any sign of old heel ulcers, depigmentation in the lower limbs, a high stop bank score and low baseline SpO2 patients, we need to call again for reassessment. So are obese patients at higher risk of regurgitation? No. That is a myth that all obese patients, we need to use rapid sequence intubation. So there have been enough and more studies which have proven that obese fasted patients are not at any greater risk unless the patient is having any signs and symptoms suggestive of RD, hiatus hernia, if the patient is for an emergency surgery or a long-standing storage disorder or a diabetes, then we need to look into the thing. And if, again, coming back to the point of care ultrasound, if we are in doubt, we can put the probe on the, abdomen of the patient and see what is the condition of the patient. Another risk factor that we need to really worry about is venous thromboembolism. Obesity is a prothrombotic state and a pro-inflammatory state. So preparing these patients with chronic leg edema, stasis dermatitis, venous insufficiency with venous ulcers, smokers, patients with history suggestive of previous venous thrombolism. Patient may say that I have chronic cough. We must, it should raise our antennae. Patient might be throwing microemboli repeatedly. So we need to investigate these patients. Polycythemia, thrombocytosis, and patients who have been taking oral contraceptives or any kind of hormonal supplements are at higher risk. So these patients, we need to give thromboprophylaxis, leg exercises, venous Doppler needs to be done. We have to start preparing them to get into leg exercises, and that they have to be educated that they will have to go into early ambulation after the surgery. So if we educate the patient about the post-op environment, they definitely do better. So identifying these patients is important. Identify patients with poor venous access. So our equipment should be available, or expert help should be available to get a venous access. So preoperative preparation, apart from routine and standard tests, we have learned how we assess the cardiorespiratory reserve, polysomnography only in very selected patients. Otherwise, nocturnal oximetry is a good test. It is like a stage 4 polysomnography, which can be done on a domiciliary basis. So a technician would come, he would attach a probe, which would, patient can do the normal activity, and it has an SD card, which can be analyzed later. So what information it is likely to give to us? What is the lowest SpO2? How long does the patient remain in the hypoxemic range during the sleep? So more than anything, it is important for documentation. So later, if we look back, the patient can be shown that yes, patient was suffering from a chronic hypoxemia, because sometimes under pressure we have to take up patients, for surgery without much time for preparation. So if we can do a nocturnal oximetry in the patient would be aware that I'm in a state of low oxygen reserves. Arterial blood gas analysis can be reserved for some patients, and venous Doppler I have already emphasized enough. So preoperative preparation, another important part is to familiarize the patient with the post-op environment, encourage the patient for walks and daily exercises. This is especially important for building up endurance. So it is not that the patient has to join a gym or go into some sort of an aerobic exercises. Patient can be taught how to do simple hand movements. The patient can be told that they can catch hold of filled water bottles at home and do simple, arm exercises and leg exercises that will help in muscle building and improve the post-operative outcome. Importance of deep breathing exercises, importance of propped up position. Patient has to be encouraged to carry their NIV device and walkers or leg supports if they are using, because even with patients who are using walkers have to be encouraged to ambulate early. So maintain head-up position, continue leg movements, continue all ongoing medications, make note of hormonal supplements like OCPs. No sedatives, and if at all my patient is very anxious, intranasal or sublingual dexmedetomidine in the dose of 0.3 to 0.5 microgram per kg ideal weight is a very, very good premedicant. Follow acid aspiration prophylaxis wherever indicated, thromboprophylaxis, pre-op nebulizations, and omit oral hypoglycemics. That is like a typical pre-op instruction. So role of anesthesiologist as a peri-op physician cannot be overemphasized. We all are aware of what is our role. So we have to start involving ourselves in every aspect of patient evaluation and patient care. So if we follow these simple things, I'm sure we will make the experience of our obese patient much safer. Thank you so much for your patient hearing. So is there any question? Yeah.
Any questions?
Pooja.
Very nice talk, ma'am. Thank you.
Thank you so much.
I have a couple of questions.
Yeah.
Not everybody who is morbidly obese is usually on a CPAP, or do they come to you on a CPAP?
Some patients would come on CPAP. That is exactly what I talked about. Not everybody would require a
So
CPAP also.
supposing you have somebody with a stop bang of 6,
yeah,
and you don't have time to do the sleep study, but if you have maybe his bloods and his bicarb is 32, so you think he or she could have OHS as well.
No.
Do you start pre-op CPAP before the surgery, or there's no rule?
Many times we do start, and why would a patient with stop bang 6 not have time for surgery is a $1 million question, because if it is an emergency, definitely. So we have to make the patient aware and the surgeon also aware that the patient is probably in a state of chronic hypoxemia and is compensating by raised bicarb. That is absolutely a pertinent question. And sometimes use of pre-op diuretics also helps in these patients. And even if it is for pre-op 12 hours, the patient should be subjected to pre-op NIV in whichever form, definitely.
So you want, so the So just a pre-op of 12 hours is enough, or would you prefer
No,
at least
you are
3
talking
days?
about probably an emergency surgery when I don't
Yeah,
have
okay.
time to prepare.
Yeah. If you
So
have
even
time,
that, yes, and post-operatively also I have to resume that. And this sort of a patient, we have to give anesthesia for, enhanced recovery by using specific anesthetic agents, by avoiding opioids, and by recruiting and by following lung protective ventilation. So if we follow all these things together and use an opioid sparing technique, you avoid midazolam, definitely in more often than not, we can have a safe outcome at the end of anesthesia.
okay, I'll
Yeah.
reframe my question. Is there a role for pre-op CPAP in a
Yes,
patient coming for
100% there
surgery?
is a role. Why not?
Yeah.
Definitely.
And for how many days? Like we are talking about a patient who's not already on CPAP, but you found out
Yeah.
needs a surgery. Like I know in India it's medical tourism as well, right? We get patients from outside India who come here just for bariatric surgery.
Yeah, yeah.
So how much time do you want them to be on CPAP before the surgery?
So exactly that I talked about in the first few slides, that there are patients who would be required to be coming for reassessment. So I put up a list, patients with small breath holding time, patient, as you said, with a high bicarb level. So these, and if I do arterial blood gas for this patient, a patient with high stop bang would qualify, and with high bicarb would qualify for arterial blood gas. So if the arterial blood gas is showing you raised PCO2, a low PO2, definitely that patient has to be first optimized on a non-invasive ventilation at least for a week. Then we call the patient for reassessment. We repeat the arterial blood gas, and invariably there is a massive improvement in there. And we tell the patient, especially the patients who are coming for bariatric surgery, to take the machine only on rent, because invariably after surgery they would lose the weight around their neck, and their sleep apnea would improve. And if they are for a non-bariatric surgery, then probably they have to be in touch with the sleep specialist for their further management.
Then the next I want about the intranasal or sublingual Dexmed.
Dexmed, yeah.
So is there a different preparation, or you use the
No,
IV?
No, the same Dexmed that is available, we have used. There are published papers for that as well.
Yeah, so how, just give it like what's the duration?
10 minutes
10
prior
minutes?
to, in the pre-op period we give them 0.3 to 0.5 microgram per kg ideal weight.
Per kg ideal weight?
Ideal body weight, yeah.
Okay. Yeah. Thank you.
Thank you so much. Thank you. Sai, you have to say something? No, we take it in the syringe, the calculated dose, and we give it under the tongue or intranasal. Yeah, they accept it very well.
And have you been using melatonin, Altonil for pre-op anxiety in any of the obese?
No, I haven't.
Okay,
No.
thank you.
That comes to a question, how common is mental psychiatry?
Yeah, so it is definitely more common than it is obvious. So the anesthesiologist should definitely spend some time with the patient alone, because a lot of times, if their attendants, patients do not reveal that. So we have to take the patient into confidence. So invariably they will talk about their low self-esteem and the fact that they have been suffering from depression, and that they are on some sort of psychotropic medication or antidepressant.
How much does that matter, or does that?
It does matter, because we let the patient continue with those medications.
But generally their cooperation and other things, is that a problem? Do you ever feel that?
Yeah, definitely there would be some patients who would be more difficult to manage, but if a patient is already optimized on some antidepressant, they would definitely do better than other patients who probably were needing some medication but could not get a chance, or for whatever social limitations they did not approach a psychiatrist. So many patients belong to that category as well. Yeah. Thank you.
One question, ma'am. Excellent presentation. What is your fluid strategy for obese patients?
Yeah, so fluid strategy as far as possible is, goal-directed therapy. So we practice goal-directed therapy only, just like we practice for any other patient, and we target the ideal body weight only. So yeah, whatever, you can target the urine output, or you can target the vitals of the patient, and the fluid management is according to the change in vital parameters, or if a patient
you put
is...
in an arterial line for every patient?
No. Only if, it's a long-standing surgery, and if patient has a conical arm and, having a cuff, fitting cuff is a challenge, then only we go for an arterial.
So just to give an example, majority of the patients, like even if it's 130, 140 kgs, the ideal body weight would translate around 60 to 70 kgs.
Yes.
So 100 to 110 ml is going to be the maintenance.
80 to 100 ml, yes.
Is going to be the maintenance.
Yes.
And what about other losses you calculate for?
Yeah, so just like any other patient.
Okay.
Yeah.
Thank you, ma'am.
Thank you.
Thank you, ma'am. One question, please. Here.
Yes. Yes, sir.
Excellent presentation.
Thank you.
Now, intubation is challenging in these patients, and extubation is even more challenging. So how do you prepare for that, especially in patients who are of OSA, or especially like patients who give history of snoring, which they, attribute it's a routine, it's been happening for a number of years. They don't give any importance to that, but it becomes significant for us.
Yes, so definitely all patients are subjected to, enhanced recovery after surgery protocols, and the ramp position is maintained into the post-operative period, and then, using lung protective ventilation and the concept of POP ventilation, perioperative open, so the alveoli have to be kept open throughout, preoperatively by using NIV, intraoperatively by using PEEP, and prior to extubation by using, recruitment maneuver. And if we have optimized the reserves of the patient, and, in most of the patients we do manage to extubate the patient on table. So the key is to maintain the ramp position till the end. And to use short-acting anesthetics and multimodal analgesia, of course. And currently, in many cases, we are practicing opioid-free techniques where intermittent ketamine is used, to provide analgesia rather than using opioids. So that is giving very good results.
What I am practicing, in addition to all this, what you have said, is that just prior to extubation, I introduce a nasopharyngeal airway.
Yes, that is definitely, it will keep the airway patent. Yeah,
that really makes our extubation much
Absolutely,
much
I
easier.
agree with that, yes.
Thank you.
Thank you.
Airway and the nasopharyngeal airway should be put in at the time of induction.
Yes.
Correct.
Yes,
correct.
yes,
See,
yes, it has to be retained till the end.
There are so many things happening at the time of induction that one tends to miss it as you.
Forget it, but
Yeah.
if you put it at the time of induction,
Yeah, definitely. Totally agree. Totally agree with you, ma'am.
Thank you, ma'am. Yes, ma'am.
One question.
The mask ventilation, if you're using the nasal airway, you can connect the universal connector and ventilate as well.
I wanted to ask you, you used to use vomiting infusion?
We don't.
Have you stopped using that?
No, we use it left, right, and center. We don't give loading dose. We start with infusion right in the beginning.
First intranasal and the pre-op.
So that acts like an infusion only. Continue intra-op. Yes, yeah. So a lot of times we can even extubate at a very low dose because it doesn't compromise the airway reflexes. That is how it is better than other sedatives. So we will have a calm patient with intact airway reflexes. Yeah. Thank you.
Ma'am. So with this we come to an end of this session. Yeah. Thank you, ma'am. Thank you very much. For just a small request to all these Jigyasu Balaks, basically there is a lot of liquids waiting at the end around 7:30. So there are a lot of liquid assets to be used. And then I think the question can go on always, right? So I invite Garima, Harjinder ma'am and Aparna ma'am. We need to present you with some mementos. Yeah. I request Dr. Bharat Bhushan to present, ma'am, please. Yeah, Bharat Bhushan to present a memento to Garima. Dr. Bharat. I request Dr. Gagandeep to present a memento to Dr. Harjinder Kohli, please. Yeah. I request Dr. Nevin to present a memento to Dr. Aparna. Dr. Nevin, please. Thank you. Thank you. Those who don't know about Nevin, Nevin flew all the way from Australia, had the daughter's second birthday yesterday, so he made it a point to attend with us today. So thank you very much, Nevin.